Hi everyone, my name is Nikki and I'm a Bachelor of Nursing student at James Cook University. Thank you for taking a moment after handover. Today, I want to share some research that I believe has direct practical relevance to our everyday work on this ward. The article I'm presenting is titled Promoting Effective Pain Assessment, a Quality Improvement Project, published in 2025 in the Clinical Journal of Oncology Nursing. This study tackles something we encounter every shift. Are we consistently assessing and documenting our patients' pain? And when we're not, what can we actually do about it? Not in a vague general sense, but concretely today. The study was conducted in a surgical oncology unit at a large 471-bed community hospital in the United States. The patient mix included postoperative patients, oncology patients, and general medical patients, all of whom may experience different types and intensities of pain. The problem that triggered the study was real and measurable. The unit's patient satisfaction scores for pain management, using the Standardized Hospital Consumer Assessment of Healthcare Providers and Systems survey, were consistently low. A follow-up audit by the nurse manager confirmed that most nursing staff had gaps in their knowledge of pain assessment and the documentation standards expected of them. Procedurally, this is a quality improvement study, not a randomized controlled trial, which is an important context that I will come back to. 49 registered nurses participated over 3 months. The intervention included a pre- and post-test of nurses' knowledge, 2 identical educational training sessions offered at different shift times for accessibility, staff interviews, and systematic chart audits to track documentation compliance before and after. The results were statistically significant. Nurse knowledge of pain assessment improved substantially. More importantly for practice, pain assessment documentation rates rose from 18 to 29% following the intervention. That's still lower than we would want, but an 11% point improvement in 3 months driven entirely by a nurse educational initiative is a meaningful and replicable finding. So what does this mean for us here on an acute ward? The study gives us more than a finding. It gives us a model. Let me be specific about what a nurse-led pain assessment improvement could actually look like in practice, because better documentation by itself is not an innovation, it's an aspiration. Here's what it looks like when operationalized. 1. Structured assessment intervals built into every analgesic administration. Every time a nurse administers analgesia, the documentation workflow includes a mandatory reassessment prompt. 15 minutes for IV medications, 60 minutes for oral medications, mirroring the national standards applied in the study. This is not new paperwork, it is embedding the standard into an existing task. 2. A standardized pain assessment tool used consistently across the team. The broader literature confirms that inconsistent tool use, or different nurses using different scales, undermines reliability and leads to undertreatment. The ward agreeing on one tool, such as the numerical rating scale, and applying it at every assessment and reassessment is a nurse-led decision requiring no additional resources. 3. Brief nurse-initiated education at handover. Not a full training day, a 10 to 15 minute monthly in-service focused on one pain assessment standard at a time. The study demonstrated that even a single targeted educational session produced measurable, statistically significant improvement in knowledge and documentation compliance. And 4. Monthly chart audits with visible, non-punitive feedback. Nurses receive a simple summary of reassessment documentation rates compared to the previous month. Chart audits and feedback approaches are supported in the evidence as effective mechanisms for sustaining practice improvement. All 4 of these actions are within the scope and authority of a registered nurse. They do not require a physician referral, a new budget line, or executive approval. They require nursing leadership, and that is precisely what the NMBA asks of us. Standard 1 calls for critical thinking and evidence use. Standard 4 demands comprehensive systematic assessment. Standard 6 requires us to evaluate and respond to outcomes. Standard 7 asks us to lead and support colleagues in improving practice. This research tells us that when nurses know what good pain assessment looks like and are supported in doing it consistently, their practice improves. And that improvement is measurable. The study has genuine strengths. It addresses a clinically significant problem with an intervention that is transparent, reproducible, and low cost. By measuring outcomes at two levels, nurse knowledge via testing and actual practice via chart audit, the researchers went beyond self-report, which strengthens confidence in the findings. Offering sessions at multiple shift times reflects a real understanding of nursing work environments and makes the intervention model more realistic to adapt elsewhere. However, there are important limitations. First, this is a single unit quality improvement project in the United States with no control group, so we cannot rule out that concurrent ward changes contribute to the improvement. Applying this to Australian acute settings, with different staffing ratios, electronic health systems and regulatory standards, requires careful consideration. Second, the outcome remains clinically sobering. A post-intervention documentation rate of 29% means that more than 70% of pain assessments were still not documented to standard. This tells us a single educational intervention is not sufficient alone. Sustained improvement requires ongoing audit cycles, regular reinforcement, and cultural normalisation, findings consistent with the broader literature on practice change. Third, the study does not report on whether improved documentation translated into better patient pain experiences, a gap that future research should address. The logical link is plausible, but not yet directly evidenced in this study. These limitations do not invalidate the study's contribution, but they do mean we should implement its lessons as part of a sustained strategy, not a one-off fix. Let me bring this back to the patient. When pain assessment is documented consistently and reassessment is timely, several plausible and evidence-supported outcomes follow. First, analgesic delay decreases. When a nurse documents a pain score after administering analgesia, the next nurse on shift has a baseline. Second, undertreatment and overtreatment risks are reduced. The study's context, surgical oncology, is important here. Patients with cancer often underreport pain, fearing it signals disease progression or leads to opioid dependence. A structured nurse-led initiative pain assessment prompts the conversation the patient may not start themselves. Third, handover quality improves. Pain that is assessed, documented, and reassessed consistently provides an accurate time-stamped clinical record. Think about your post-operative patients, your elderly patients who may minimize their pain, your patients whose pain required skills interpretation of non-verbal cues. All of these groups benefit from structured, documented assessment. These are issues that nurse-led initiative alone cannot fully solve, but they are not reasons to do nothing. They are reasons to start with what is within our control. I want to leave you with two questions to reflect on. First, if we ran a chart audit on this ward tomorrow, checking what percentage of analgesic administrations had a documented reassessment, what would we find? And would we be comfortable with that number? Second, which of the 4 practical steps I described, standardized tool use, reassessment intervals, monthly in-service, or chart audit feedback, could realistically begin on this ward in the next month without waiting for anyone's permission? To summarise, the research provides clear, reproducible evidence that targeted nurse-led education improves both pain assessment knowledge and documentation compliance. This research affirms something the NMBA has long asked of us. The nursing practice should be evidence-driven, critically evaluated, and continuously improved. The registered nurse standards for practice, particularly standards 1, 4, 6, and 7, are not abstract obligations. They describe exactly what it looks like to take a study like this one and turn it into better care for the person in the next bed. The gap between research and practice does not close on its own. It closes when individual nurses decide to act on evidence, concretely, consistently, and in collaboration with their team. 4 structured steps: a standardized tool, a monthly in-service, a transparent chart audit. That is a realistic bridge between the study and this ward. Pain is not a background condition. It is the lived experience of our patients every shift. Let's assess it, document it, and follow it up, because that is what a safe, evidence-informed nursing care looks like. Thank you.